uptake, and cancer inequalities. So I see Francois has just set the recording there. So everybody is now being recorded. So if you want to leave your video off, that's perfect. And there is also a chat function where we will do questions at the end. So we're delighted to be talking today, Kalya and myself, looking at the numbers behind the needs. And we're going to explore cancer statistics, incidence. We're going to look at outcomes, and Kalya then is going to focus on screen uptake and inequalities. I don't have control of the slides, so Kalya is kindly going to move on through the slides. So if we can go to the next slide, Kalya. That's great. So, firstly, we really want to acknowledge the work of the CUPID cost action, so understanding cancer prevention in people with intellectual disabilities. And this work is based upon the work of the CUPID cost action across the four work packages, but specifically relating to work package two. So, next slide there, Kalia. So in terms of conflict of interest, before we begin, Callie and myself, we declare that we have no conflicts of interest to disclose in relation to this presentation. And the content presented is based upon our professional, academic, and our research perspectives. And there's no financial or personal interests have influenced the material that we are going to share today. So next slide, Callie, please. So what we're going to look at, as I briefly said, is the overview of the evidence base relating to cancer in people with an intellectual disability. We're going to focus on cancer incidence in people with intellectual disability. We're going to look at outcomes in terms of mortality, survival, and premature death. We will explore diagnostic patterns, where we will explore stages, delays, and emergency presentations. Kalya will specifically focus later on in the presentation upon screening uptake and coverage, and she will explore the barriers to earlier detection and healthcare inequalities across the cancer pathways. So what we're seeing that there's a rising cancer or interest in cancer in people with an intellectual disability. And over this past few years, in parallel with the CUPID cost action, we're seeing increasing attention, particularly as life expectancy in this population has improved. So as people with intellectual disabilities are living longer, they're increasingly experiencing age-related conditions. And cancer, the greatest risk factor for cancer development is age. However, despite these improvements in longevity for people with intellectual disability, there is now growing and consistent evidence that outcomes, that cancer outcomes in people with an intellectual disability remain significantly worse when compared to the general population. So what makes this particularly important is that these differences are not simply due to different biological factors or profiles experienced by people with, or presented with by people with an intellectual disability, but rather they reflect the systemic and persistent inequalities across the entire cancer care pathway. And that's very much from prevention to early detection through to diagnosis and treatment and into survivorship and end-of-life care. So today we're not going to explore what the evidence shows, but Kalia later on will focus on where these inequalities arise and how and what this means for policy and practice for people with intellectual disabilities. So as we move on, we suppose one of the key challenges in the field, and this is something that we're trying to grapple with across the CUPID cross action, but more broadly as researchers in this area, is that data can be misleading when it's looked at in isolation. And what we see is that there are now several large scale studies, and some of these leading authors are very much part of the CUPID cost action. And what they're reporting is that overall cancer incidence in people with intellectual disability is similar or lower than in the general population. And while at first glance this may suggest that cancer is potentially less of a concern in this group, that is very, very misleading. So when we look deeper into this, what we start to see is a very different picture emerges. So despite lower cancer incidence, Mortality is higher, as I've said, and outcomes are worse, particularly with cancer being diagnosed at a later stage with poor screening uptake and poor overall survival. So what the evidence base shows us is that it does not suggest that despite maybe a similar or lower incidence rate of cancer, it does not it's not a protection from cancer more broadly. So what we are starting to see is a pattern of underdiagnosis, which we will touch upon in the next few slides, a younger age structure, but also when we consider the concept of competing mortality for this population. So what we're starting to see is that people may live and die from cancer, but due to issues with competing mortality, and then with the issues regarding potential late-stage diagnosis and access to treatment and diagnosis, we see a really worrying pattern. So what we look at then, in other words, when we look at the next slide, Kalya, the issue is not a lower burden, it's potentially an under-recognized burden for this population. So as we move on then to, I suppose, our first looking at incidents, and I suppose across several countries now, we're starting to see a consistent pattern with regarding to incidents for cancer in people with an intellectual disability, but also worse outcomes. So, for example, if we take a look at this study from our colleague Martin Kuipers in the Netherlands, we see that they found in their Dutch cohort, which was a significantly large study, the incidence was almost half that as what was observed in the general population. But I suppose importantly, those cancers were diagnosed at a younger age and at a more advanced stage. Martin and colleagues also found that there was significant variation that exists across the intellectual disability subgroups more broadly in terms of cancer types. So, for example, for people with an intellectual disability, there was a lower odds of skin cancer and there was an elevated odds of cancer of unknown primary origin, which is a consistent finding across these large scale studies. So in Martin's study, the fewest cancer diagnoses occurred, interestingly, to those who are entitled to long-term intellectual disability care. Uh, but interestingly, which I think this is a real interesting finding, he found that those who uh, lived independently were at greater risk of developing cancers of the digestive, respiratory, and the female genital organs. So this may signal exposures to different social determinants of health for people who are living independently, and I think that's quite a striking finding. So as we move on then from the Dutch study. Another study then in Scotland. So this was by Laura Ward and colleagues. So again, in Scotland, this was a comprehensive coverage of all administrative health records identifying people with and without intellectual disabilities. And what they found was that fewer adults with an intellectual disability had a record of cancer. And again, they also found that there was a lower incidence overall. But again, another concerning finding was that they found that even though there was a lower incidence for people with an intellectual disability, mortality was higher for this group. So similar to Martin's study in the Netherlands, there was higher ending cancers of primary unknown origin within this study too. So I suppose what we're saying when we start to look at the evidence base here is that adults with an intellectual disability are more likely to die of cancer than in the general population. We move on to the next study then, which is only recently been published, another large study, population-based study by Kennedy and colleagues in the UK. And they linked primary care hospital data and national cancer and death records in England. Essentially, they compared 180,000 people with an intellectual disability to a matched sample of 3.4 million to the general population. And again, they see a slightly lower overall cancer incidence in this population. But strikingly, and I suppose very much concerningly in this population, they see a higher risk of diagnosis and a much higher risk of diagnosis occurring below the age of 50. So Kennedy and colleagues conclude that individuals with intellectual disability have got a very high cancer risk. they're diagnosed, and this was an interesting finding. People with an intellectual disability were diagnosed more outside urgent suspected cancer pathways. For those who were diagnosed, they received fewer treatments, they had a poorer prognosis, and fewer diagnoses of some cancers. And the fewer diagnoses of some cancers may indicate underdetection. So again, worrying findings, but again, a slightly lower overall cancer incidence. We move on then to a study which is published in 2021 from Leah and colleagues in Sweden. And we see a marked difference here because what we see in this study was that where people were followed from birth to the age of 43 years, those had an increased risk for any cancer. And this is in contrast to, I suppose, the aforementioned findings. And I think when we see that these findings may seem inconsistent at first, they're actually telling a consistent story. So when we move on, then we're seeing that the findings from the Swedish study in comparison to the Dutch, English, and Scottish study, they're not necessarily contradictory. What we're likely seeing is that cancer in is being diagnosed at a later stage. There, in many cases, cancer may not be diagnosed at all, and that may be particularly the case as people get older. So, in comparison then to the Dutch or to the Swedish study, regards where people were covered where were followed up from childhood into adulthood to the age of 43 years. Um, and so we're seeing higher all-cause mortality may mean that some individuals may die from conditions before cancers that are typically occur in older ages are ever identified. So I suppose that the point that we're trying to make here is lower recorded incidence of some cancers in people with an intellectual disability should be interpreted very cautiously as it may reflect underdiagnosis, reduced screening or diagnostic investigations, but also the concept of premature mortality. So people with an intellectual disability also dying at a younger age, and also, I suppose, the difference in the populations that were explored in these studies. So I suppose what the evidence shows us in terms of specific subtypes of cancer, there are specific nuances that we need to consider. Uh, so excess risk is not uniform across all cancer studies, but what we are seeing is that there is a specific there is a specific trajectory or pattern that appears more consistent for a specific type of cancers in this population. So across the studies there that we have seen, and also from a review from Amina Benda and myself, we're also seeing that there is a pattern of cancers of the unknown primary, so being diagnosed at later stages, cancers of the genital cancers, kidney cancers, CNS cancers, sarcoma, and also esophageal cancers. So it's important to recognize that these patterns are not identical across all studies, and they speak to the methodological challenges that we have within the evidence from the Kennedy study, from the Dutch study, from the Scottish study from Ward. So there is obviously very independent factors, also such as the age of the cohorts, which we've seen in the Swedish study. Uh, while there are some consistent signals with regards to the specific subtypes of cancer in people with intellectual disability, we need to be very careful that we consider these findings carefully, and consider also diversity within the population. But I suppose, notwithstanding that, if we move on to the next slide, then Kalya, what the evidence base does show us quite clearly is that there's an earlier burden. So cancer diagnosed and cancer death occur at younger ages. That is very clear. We are seeing there's a higher incidence and a much higher mortality and late recognition across the evidence that exists. We're seeing that uterine and ovarian cancers are repeatedly elevated in some cohorts, and we're seeing a raised incidence appears across large national studies regarding testicular cancer. The Kennedy study shows us that there's higher risk or especially clear for CNS and sarcoma in the UK. So I suppose several site-specific patterns are reoccurring across these larger studies. Uh, but the syndromic literature, and I would ask everybody to review Amina Banda's systematic review with the syndromic association of cancers that she looks at from 2024. And it's important to say that broad intellectual disability cohorts do not have a single biological cancer profile. So, for example, when we look at Down syndrome and other genetic syndromes, the risk can shift strongly for specific patterns, for specific cancers, and in that case, when we consider cancer and leukemia. So, we should not take population averages that replace individual assessment of a person's needs with an intellectual disability with regards to the development of cancer. So moving on then, when we consider, I suppose, mortality, late diagnosis and pathway failure, when we move from, I suppose, incidence and subtypes of cancer in people with an intellectual disability, uh, we start to get on firmer ground with regards to the evidence being much more clearer. So, as we say, mortality is much higher in people with an intellectual disability. And this Dutch study from Martin Kuipers in 2021 identifies that mortality is consistently higher among people with an intellectual disability. So in this study, cancer accounted for 22% of all deaths of the population, and overall cancer mortality in this study was nearly 50% higher than expected. So when we consider another important point from this study is that the age of death for people with a cancer and an intellectual disability was age 63 years, which speaks to the epidemiological profile of mortality more broadly for people with an intellectual disability. But again, this was 10 years younger than that from the general population. When we take a look at mortality, late diagnosis, and pathway failure, and I've pointed towards this with regards to the Kennedy study earlier, we're starting to see a similar pattern when we look at the cancer care pathway. So when we take a look at from the Kennedy study, they found that around 50% of people with an intellectual disability were less likely to get an urgent cancer referral. That speaks to, I suppose, the inequalities and inequities for people with an intellectual disability here. But also, Kennedy and colleagues found that even when those who were eventually diagnosed with cancer, they were still less likely to have been referred through an urgent pathway. Uh, and they also find that this gap and inequity continues into treatment. So few people with an intellectual disability receive treatment within 6 months, and the overall survival after diagnosis for people with an intellectual disability was much shorter. In fact, it was less than half. It was greater than half the time, so around 4.4 years for people with an intellectual disability versus over 9 years in comparison to the general population. This evidence is not just specific to the UK. So one of our other colleagues too, Rebecca Hannisford and Alison Maher from Canada, they also found a similar trend that individuals with intellectual and developmental disabilities, I may add, were more likely to be diagnosed when cancers had spread and there was a higher risk of death after diagnosis. So not just across, within our universally within one healthcare system like England, we're seeing the same patterns and trajectory in terms of mortality, late stage diagnosis, and pathway failures across countries. Countries where there is universal healthcare available for people with an intellectual disability. So what we're starting to see is consistent evidence of issues with access to care and poor outcomes along pathway failure. When we then, I suppose, look at England and Scotland, so we take a look at Pauline Heslop, so in 2022, Pauline in England looked at data from the Learning Disability Mortality Review at the time. And again, she found that late diagnosis again is a key issue. So when she looked at the amount of people presenting who died from cancer, presenting 35% of those were emergency presentation. And while in the general population, there will be a certain amount of people with intellect in the general population who will be diagnosed as an emergency presentation. This is a lot higher in this study. So what Pauline found. And of that, among half who were diagnosed were also at stage 4 when they were diagnosed in an emergency presentation. So, and I suppose another important finding from the study in England was is that among those who died from colorectal cancer uh, in the HESLOP study in England, a large proportion of those were below the age for the current screening. So this raises the question about whether the current screening strategies are appropriate for this population. And I may add, but I don't have it in there. And I can see, I think Dr. Chris Sinton is also online here. Chris and myself and a few colleagues undertook a review looking at, the benefits and harms of screening for people with intellectual disability. We also found that there was no evidence at that stage, and that is also available online. If we take a look at, I suppose, the Ward study then in Scotland, we also begin to see a similar pattern in Scotland, where both, even though incidence was lower overall as we've reported on, mortality was much higher for cancers and cancers of unknown primary origin. And again, this is potentially suggesting, a late or missed diagnosis at that stage. So I suppose when we considered the evidence together across these countries, they point towards a consistent problems and delays at multiple stages in recognizing symptoms, in referral, and in diagnosis. And these also ultimately contribute to poor outcomes. So just before I finish up and hand over to Kalya there, we take a look at what does the evidence base show us. So the cancer mortality is higher and survival is worse for people with an intellectual disability. This is a clear inequity. People with intellectual disability are more likely to be diagnosed at an advanced stage. Excuse me. Mortality in cancer diagnosis is about 50% higher. And there also is survival differences, and these vary by sex. So overall cancer mortality is higher, particularly among females, and we're seeing excess deaths in regards to colorectal and kidney cancers, female cancers, and metastatic cancers. So I'm going to leave my part of the presentation there now, and I'm going to hand you over to Dr. Kalya Lima, who's going to take you from here. Thank you.
Thank you, Martin. Thank you, everyone, for joining us. So based on everything that Martin has said, the question becomes, where in the pathway are these inequalities arising? And one of the most important aspects is the surveillance of symptoms and screening. So the surveillance of symptoms is an important strategy, and screening is one of the most effective tools for early cancer detection in general. But across all major programs, for example, cervical screening, breast, and colorectal, participation is consistently lower among people with intellectual disabilities. And the most evidence that we have is from higher income settings. For example, cervical screening uptake is around 35%, with individuals being about 70% less likely to be screened compared to the general population. And this pattern is consistent across countries, but importantly, these inequalities are not limited to screening alone. Studies show that adults with intellectual and developmental disabilities experience disadvantage at multiple points along the cancer pathway, from prevention and early detection through diagnosis, treatment, and outcome. This is not a small difference. This is a major gap in preventive care, and it has direct consequence for stage at diagnosis and survival. So here we focus on screening participation gaps in UK. So what we see here is a consistent pattern across different types of screening. People with intellectual disabilities are less likely to participate. For example, cervical screening rates are about half that of the general population. Similar, though slightly smaller gaps are seen for breast and bowel screening. But one important finding here is not just lower uptake, it's exclusion. Around a quarter of women with intellectual disability were excluded from cervical screening, compared to only 6% in the general population. And importantly, these exclusions are often recorded as refused or inappropriate. So this may raise some questions like, is this true patient choice, or does it reflect system level barriers such as communication challenges, lack of support, or assumptions about capacity? So overall, this highlights that inequalities in screening are not only about participation, they also involve how eligibility and access are determined within the healthcare system. This pattern is not unique to the UK. We see very similar inequalities in other countries. For example, in Netherlands, screening participation is lower across all major programs. Cervical screening participation is around 45% compared to over 68% in the general population. For breast and colorectal screening, we see the same pattern. Overall, people with intellectual disability are about 60% less likely to participate in screening. But what is particularly important in this study is that it goes beyond participation. It also looks at the quality of screening. And what we see is that, sorry, what we see is that most of the results were considered invalid or unreliable. So suggests ongoing accessibility and quality issues even after attendance. And finally, looking at evidence from Ontario, we see the same pattern once again. This is important because it shows that these inequalities are consistent across different healthcare systems. So among women with intellectual disabilities, they were nearly twice as likely to be unscreened for cervical cancer and about 1.5 times more likely to be unscreened for breast cancer. When we look at the broader adult population, we also see lower participation in colorectal screening. Individuals had lower chance of completing bowel testing and were less likely to be up to date with screening. So across cervical, breast, and colorectal screening, the pattern is very clear. Low participation is consistent and substantial. So when we combine this with the early finds from UK and the Netherlands, we see a very strong and consistent message across countries. They are not isolated findings. So the key question now is, why do these gaps persist? And that brings us to the barriers to screening and early detection. So the evidence suggests that there is no single barrier. Instead, screening participation is shaped by a combination of factors operating at different levels. Starting with individual factors, fear and anxiety are commonly reported. Screening procedures can be uncomfortable or unfamiliar, and without appropriate preparation, this can discourage participation. In terms of knowledge and awareness, there are often misconceptions about eligibility or need for screening, as well as lack of accessible information. Standard health information is not always adapted to different communication needs, which creates a barrier before individuals even reach services. Social support also plays a crucial role. People are more likely to participate in screening when they have support from caregivers or support persons. For example, help with understanding information, attending appointments, or navigating the system. Finally, healthcare system factors are a major part of the problem. These include communication challenges, difficulties around informed consent, and a lack of confidence or training among healthcare providers in supporting people with intellectual disability. So what we can see that screening inequalities are not simply about individual choice. They reflect a mismatch between the way services are designed and the needs of this population. When these barriers are addressed, we see clear facilitators emerging across different levels. Starting with knowledge and awareness, education is really important. When individuals receive information about screening and accessible formats, for example, through social media or tailored communication, participation is more likely. The living and support environment is also critical. People are more likely to attend screening when they live in supervised settings or have support from cares. Healthcare engagement is another important factor. Individuals who already have contact with healthcare services are more likely to take part in screening, suggesting that familiarity of care with care can make a difference. And finally, a higher income and access to dual insurance coverage are associated with better screening participation, highlighting the broader influence of social determinants of health. So, screening participation can be improved when support, access, and communication are in place. So, moving beyond screening, we see that inequalities continue across the entire cancer pathway. Overall, people with intellectual disabilities receive related, less cancer-related care, and these inequalities tend to increase with age. We also see greater disparities among females and consistently lower use of screening programs. And when we look more closely at the pathway, the gaps becomes even clearer. There are fewer urgent referrals for suspected cancer. This is followed by lower rates of treatment within 6 months. And another important point is that some cancers may appear less common, but once diagnosed, they carry a higher risk of death. This again suggests delays in diagnosis and difference in access to timely and appropriate care. So, and as we have seen, the barriers reflect a combination of factors involving emotional, informational, practical, and healthcare system level challenges. Diagnostic or overshadowing can occur where symptoms are attributed to the intellectual disability rather than investigated as potential cancer. This can lead to delayed investigations and missed opportunities for early diagnosis. We also see a tendency towards less intensive treatment, sometimes without strong evidence, and very limited research on survivorship in this population. So, if inequalities are built into the system, the next question is how do we change that? So, based on everything we have seen, what are the implications? So, the first key point is that the evidence support a shift from general statements about equality to concrete changes in how services are designed and delivered. In terms of measurement, we need to move beyond cancer incidence alone. Indicators such as mortality, age at diagnosis, stage at diagnosis, emergency presentation, and the route to diagnosis are much more sensitive for identifying inequalities in this population. When it comes to screening, organized programs need to incorporate reasonable adjustments as standard practice, not as exceptions. This includes practical changes such as providing accessible information, supporting decision making, allowing longer appointments, and introducing roles such as patient navigators. It also involves ensuring that staff are adequately trained and that logistical barriers such as transport, or need for a support person are addressed. Another important area is primary care, and it's primary care and referral pathways. There is a need for a lower threshold for investigation, particularly when symptoms are non-specific or when communication is more challenging. The referral gap we have seen in the data makes this a clear clinical priority. So overall, improving cancer outcomes for people with intellectual disability requires not just awareness, but systematic change in how care is delivered. Building on those practical changes, there are also important implications at a broader system and policy level. First, screening policy itself may need to be reconsidered, not just improving uptake, but tailoring how screening is delivered. The literature increasingly raises questions about whether current screening programs are fully appropriated for people with intellectual disabilities. For example, cancer may present at a younger age, or standard procedures may be difficult to tolerate, which suggests that both the time and the methods of screening may need to be adapted. Another critical issue is data. Cancer registers, screening systems, and routine health records do not always reliably capture intellectual disability. Without this information, inequalities remain partly hidden, and if we cannot see them clearly, it becomes much harder to address them effectively. Finally, there is a need for clear guidance or treatment on treatment adaptation. Current evidence shows lower treatment rates and variation in care, but there is still limited guidance on how to adapt cancer treatment safely and appropriately for this population. So, improving outcomes will require not only change in clinical practice, but also improvements in data systems, screening policies, and clinical guidelines. So, to bring everything together, I will finish with the key takeaways from this presentation. So, the evidence now supports four clear conclusions. First, although record cancer incidence in people with intellectual disabilities is often similar to or even lower than in the general population, this not translating to better outcomes. Second, cancer tends to occur earlier and mortality is higher, meaning that people are not only more likely to die from cancer, but to do so at younger ages. Third, screening participation is consistently and lower across all major programs, including cervical, breast, and colorectal screening. And finally, these inequalities are not due to a single failure point. Instead, they reflect cumulative disadvantage across the entire cancer pathway, from prevention and symptom recognition through referral, diagnosis, and treatment. So, overall, the key message is clear. Improving cancer outcomes for people with intellectual disabilities requires system level change across the whole care journey. So, this is not just about access to care, it's about ensuring that care is designed to meet the needs of everyone. So before we finish our presentation, I would like to invite you everyone to attend the next webinar called Beyond Words, a focus on augmentative communication with Dr. Olivia Kowalski, I think, sorry if I said wrong, and Dr. Margaret Denny. So these are some of the reference that we used in our presentation, our research, and thank you.
Thank you, Kalya, and thank you everybody for attending. This recording will be made available online, and also a copy of the presentation will be made available. We've got a few moments for a few questions. We can actually turn off the recording, Francois. We don't need to record the questions, I would imagine. And if people have anything specific they want